What training or tools are required to use Conometric correctly?
Talking about the trainings, of course, this is something like cosmic, but there are some tricks and some points that are necessary to take and attention to take an experience from us, because we passed through all of this time of couple years while looking for the best. I think that, of course, to take this information straightly from us, to see some procedures including surgery and prosthetic as well, it's much more better and gives more benefits for our doctors who are going and who are streaming to understand and to use this type of treatment in their daily practice.
How does ROOTT support clinics that want to transition? Starter pack, masterclass, assisted surgery?
For me, working about 25 years in implantology, doing surgery, doing prosthetic treatments, I would see the prosthetic, all the types of prosthetic on the second floor. I mean, not here, not in the connection abutment implant. This part should be closed with a primer abutment, and that's it for long years, long years. Of course, we're changing, we're getting older, and tissues as well as shrinking. And after maybe 10-15 years, we will have necessity to remove this abutment and to take another one, maybe shorter, to go again into soft tissues, to have new profile. For the period of fresh treatment, what I see, it's much more better to work on the second floor. I mean, to have all connections on the level of soft tissues, to go in soft tissues 1 to 2 millimeters to prepare the bed for our prosthesis, and then just only depends what kind of primer abutments we have, what possibilities for single crown, for bridges, for total prosthetics. We having couple solutions of primer abutments, we can close all demands. Looking at every clinical situation, we can choose which abutment with much more stability to choose. Of course, as I said, Conometric is very stable, but it allows convergate between straight abutments until 10 to 15, maybe 13 degrees. Of course, we have angulated abutments for Conometric, but using with another features, abutments going for fixation on the level of soft tissues, we will be more friendly for environment around the implant. We will be technically more friendly, because if in case we made some mistakes, these mistakes will appear here, but not in the level of the bone. So for the future, I think that the best way will be to go more far from the implant, to go, as I said, on the second level, to close this implant abutment connection on the bone, and later on to go on the upper floor using different kind of abutments, Conometric as well.
How do dentists and prosthodontists react to Conometric in practice? Concerns versus enthusiasm.
I think that our colleagues will discuss more about their feelings while using this type of solutions, but what we found while communicating with them, while collaborating with them, because I'm not just only a surgeon, I'm also a prosthetic treatment doctor, and I can compare what was previously and what it is now, and I can discuss with our prosthetic doctors, with our colleagues from other clinics, especially when we started to use individual zirconia gingiva formers. The game changes, and when we started to use individual zirconia gingiva formers, the game strongly changed, and now we give very nice emergency profile. We gave possibility to start prosthetic without any additional preparation of soft tissues while streaming to more natural surroundings all around the crown, and this of course is much more friendly, much more easier, and much more lovely and beautifully for our prosthetic colleagues. But I think they will comment much more deeper from their point of view.
How does Conometric work technically? What's the difference in connection, material, and precision?
As I said, Conometric is double abutment system. A primary abutment goes with a connection into the implant. Secondary abutment with a maximum precise comes to the mouth with the crown and sits on the primary abutment. And while it sits to its final position, the connection between two metals is so firm, so rigid, that it is impossible to reattach them by fingers, by arm, and it stays very firmly and predictably in the mouth. Meanwhile, when we have to remove them using special methods with special hour instruments, it's very easy to remove it from the mouth. We had made an investigation while in the university. We fixed to the primary abutment 100 Conometric crowns from titanium. We fixed with different kind of cements. It was like an investigation what the windings on the top of Conometric have, what kind of possibilities. So we used different kind of cements, including glass ionomer, resin type cements. We used resin dual curing cements, different cements we used. It was 3 or 4 types of cements, and we fixed cement Conometric crown. That means we cemented metal to metal. We put all these samples into incubator. We left in incubator about 2 weeks. We left these samples into incubator to improvise the environment of the mouth, and later on we tried to refix these superstructures while using our retrieving instrument for lifting of the Conometric crowns. And for our surprise, we received 100% of success. It was an amazing. So why these windings on the top of Conometric are so important and so comfort for doing prosthetic treatments? Of course, while we are doing prosthetic, we are not using cement. This was just an investigation to understand the possibilities of windings. So this is what we would like to say, that technically the features and construction of Conometric is very good and very predictable with the possibilities of all prosthetic manipulation.
How does the workflow look in practice compared to traditional methods? Which steps are eliminated?
Working clinically while doing single crowns, while doing bridges, as I said previously, Conometric is more dedicated to molar and premolar areas, sometimes to canine areas. If the canine is stronger, you want to have good fixation, good stability of the implant abutment connection. And while doing prosthetic treatment in the clinical way, while doing single crowns, bridges, as I said previously, Conometric is more dedicated to molar and premolar areas, sometimes for canines. We observed that while doing these prosthetic procedures, we are not irritating these deeper tissues. We are not reconnecting the abutment from the implant. This gives more comfort for tissues. This gives me more comfort for patient, because patient don't feel any pain while seating bridges. We can observe if sometimes the abutments are diverging or converging to each other, when there's some part of the abutment might be involved not to let the proper seating of the bridge. So we can looking by eye to make some grinding a bit and let to go the bridge on top of the superstructures of our abutments. Meanwhile, while doing bridges in implants, in connection straightly with implants, we cannot observe, and sometimes we are suffering of trying to see bridges when, as I said, implants are converging or diverging from each other. So this is also much more comfort for the doctor. And when we have more divergation with the implants, we have angulated abutments for Conometric fixation, and then we can use fixed bridges even when the implants can diverge navigate until 24, even sometimes 40 degrees. So it's a big divergence between implants and not using multi-unit abutment that are more influenced by screw, but use conometric, which is much more stable and much more predictable mechanical way of understanding.
Do you have case examples where conometric led to fewer complications?
We, in this long time period of doing prosthetic treatments on this type of fixation, we found additives and we found about 8 additional features comparing to regular fixations, different type of fixations, while using conometrics. One of them is that we have the most strong connection, very firm connection, or let me say the maximum hermetic connection, which is very friendly to all surrounding the implant. I mean bone, I mean soft tissues around the dental prosthetics, which are fixed on conometrics. Almost forgot the word peri-implantitis. That is a headache. It's a nightmare for us if talking 10-20 years of our solutions that we've previously. For today, this kind of problems almost disappeared from our daily clinical findings.
Other data or studies supporting better tissue healing, patient comfort, or long-term stability?
If talking about some investigations we made, as I said previously, an investigation, what are the possibilities of conometric crown, even while if someone decides to additionally to cement it. I'm talking usually about monolithic implants. If some doctor will find the necessity to do single crown of monolithic implant. Described it previously and said that we made an investigation while cementing of about 100 examples of it. But talking about what we can observe clinically, so this is not an investigation looking at the surrounding pH of the fluids that are around the crowns, and we found a more alkaline surrounding fluid comparing conometric crowns and regular crowns. Near the regular crowns, which have been fixed on regular abutments, was more acid comparing to these that we had with conometric. So this also shows that this type of fixation is more friendly because the environment is more alkaline and processing of bacteria, they have less influence for tissues which are around the conometric fixation. So conometric is an additional option in prosthetic treatment while making fixed dental prosthesis on dental implants. It's additives. We found that this way of treatment gives more positive features for results that we are streaming to. Having a lot of years of experience while using this type of treatment, we found that for today this is one of the best and strongest solutions for single crowns or bridges while doing prosthetics fixed on the implants in the mouth.
What are the most common problems with screw retained or cement retained restoration in daily practice?
So while we are doing screw retained prosthetics, it depends on what kind of fixation do we have. Implant abutment fixation. If we have good stable cone fixation, of course, here the influence of the screw might be depending on how precise and how firm is cone. Influence of the screw is not so strong and big, but when we are doing some more flat fixation, as we say internal hexagon fixation, these superstructures are a bit floating in the implant. They are not very polite. All surroundings around the implant, I mean bone, soft tissues, and then of course we have mechanical problems with the unscrewing, screw loosening, screw breakage. So here, while using conometric, first of all, we can firmly to protect connection implant abutment in the bone, in the most sterile zone and most sensitive zone, and later on to go upper on the second floor while using conometric crown, working not here as regular implants in the level of the bone, but going upper on the soft tissues. And soft tissues have barrier zone, epithelium, and this is much more friendly comparing to this deeper zone. And so why as well this method is much more comfort to the mouth.
In what cases do dentists experience problems with screws or with cement?
While doing cementing prosthetic, we have two nightmares. One nightmare to clean all the cement surrounding the implant. Sometimes you feel that, okay, I cleaned everything, but in fact, some residues of the cement stays around the crown, and later on it can be a starting irritation and starting point of future on peri-implantitis appearance. Another nightmare is service of the prosthetics. We have no retrievability of our dental prosthetics because when we put dental prosthetics on the implant, first, of course, we have to think how to put correctly it, but never ever we have to forget how I will take it after some time. 1 day, 1 year, 5 years, 15 years, 20 years, it will come to you, maybe to your colleague. But if your dental prosthetic, especially big dental prosthetics with bridges, crowns, if it is just cemented, is a nightmare to cut it, to take it from the mouth, while we have possibilities for retrievability to remove the prosthetics very easily with some methods that allows us not to destroy them. It's much more comfort, much more easy, and it is big advantage, additional feature for this type of fixation.
How do these issues affect clinical efficiency, cost, and patient comfort?
So this that I mean, it's a big comfort for our patient. Of course, every comfort, every additional feature also costs. While using Conometric Solution, we know that we have to use two abutments: primary abutment that fixes in the implant and secondary abutment. Technically, Conometric is very similar to multi-unit. Just multi-unit has big angulation, much more degrees of slope. It's about, in our system, it's about 30 degrees of slope. Meanwhile, Conometric has 5 degrees of slope and it's very rigid fixation. So we have double abutment, and of course, costs of this treatment a bit arises. But medicine and health is this part of our life where we have to invest a bit more. And if doctor and especially his patient has a possibility to pay for it, I would like to say yes, of course, choose every time the best what we have for today of different kinds of treatment, including Conometric Solution as well.
The surrounding of prosthesis is more clear, more beautiful, look healthier, and less plaque, I think. So it's perfect solution for me.
I wouldn't say a very big range, but we had some percentage of peri-implantitis, the inflammation surrounding tissues around the implant, and it was a bit a nightmare for us while doing some solutions like treating or sometimes removing implants. What can you say about today? Do you find often this kind of disease of implants, or what can you say regarding this question?
So for today, I think this is more, I don't know how to say, it's more better. I think it's better way to do this solution.
And you find less, almost you don't find peri-implantitis?
No. Sometimes in my practice, I think just a couple of times I think I see peri-implantitis, but in this solution it's more less, I think. In my medical experience, I don't see any kind of peri-implantitis with Conometric Solution. So I think it's perfect.
Yeah, sure, I agree with you, because again, this is as well a nightmare for us, for our patients, and having a small percentage of such kind of problems, or even have no, very good for us and for our patients as well.